Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. And today I'm joined by Dr. Dominique Williams, Adult Nutrition Medical Director at Abbott, a global healthcare company. And she and I connected at several of the obesity care meetings in the past couple of years, but I want her to tell you a little bit about her vast background, and she and I are going to talk about the American Diabetes Association conference that we just got back from in Orlando.
Yes, so I'm super excited to be a guest today. And as Nina was saying, we've seen each other a little bit of everywhere, but more recently have had the opportunity to sit down and connect. My clinical background is in obesity medicine and also in academic medicine, teaching medical students and residents about the care of patients with obesity and how to do that thoughtfully, holistically, in a way that patients feel seen and heard. And I think that's where we've bonded the
Yes.
most and had our most resonant conversations, and how we can support others to do that. So as our careers have transformed and changed, we've had more time to spend more time. So it's my pleasure to join you today.
Thank you so much. Yeah, I think you and I definitely need to schedule time to talk about language and conversation and communication styles, because I think there's a lot in our collective experience to share, and our
Absolutely.
passion, of course. But I did want to talk a little bit about how the American Diabetes Association meeting went, because it was my first time, and I know it was your first time as a grown up, maybe.
Yes. As a grown-up doctor, yes. I think the last time or the first time I went, I must have been either a med student or a resident, and I won't share how many decades ago that was. So let's just say, for all intents and purposes, this was my first time attending as a grown-up clinician.
And it's a different meeting. I've been in the obesity care field for almost 20 years myself, so I know those meetings, I know the flow, I know the cadence, I know the people. So it was a new experience for me, being around a lot of international and research folks, not as many practitioners, but maybe. And so it was a bigger group. The sessions I thought were really intense in a, like you and I say, a nerdy kind of a way, and it was an
Hmm.
opportunity for us to go deep into some of the real clinical information, like how to apply that research to clinical practice. And there were also some pretty practical talks. A couple dietitian colleagues of mine did talks on how to really translate this to the patient experience. So I thought it was a really interesting meeting, and it was also really cool for me to be there at one. I've seen them announce, surmount trial information, or
Hmm.
step one, or all of the
Hmm.
different clinical trials. When they released that information, I'd never been in a talk where it was like, this is the first time you're hearing it. So it felt kind of cool to be part of that cutting edge, first time vibe as well.
Yeah, I agree. And I was struck as well about the international attendance and learning as well about some of the research that's happening outside of the US. I just really felt like I was in a brave new world, that there was just a spirit of innovation and a spirit of leveraging maybe what we've known in the past, and then really kind of poking you as a learner or as a clinical scientist or researcher, really just poking at maybe some assumptions or things that we've held on for a while, and then it's like, nope, we've leveraged it in a different way. We want to show you this new research, and from that, I felt like the practicality of it was patients are more informed now than maybe when I was training or I was early in my career, because we
Mm.
didn't have as much digital access. And so some of the things they have access to peruse or look at. And so I felt like having that chance to go to the sessions and listen to the explanation of things, or the reason behind or what the results were, that's an opportunity to engage in different types of conversations with patients and colleagues who might come to the table with a greater fund of knowledge than what we might be accustomed to before. But as you said, the nerd level was high, so there was just so many choices to make about where to spend your time or how to engage. I was struck by, um, I did notice some shared names, so names that I was accustomed to seeing in the obesity space, that it was kind of comforting, or like, oh, okay, I absolutely know who that is and the work that they do. But it was interesting to see them in this such a large conference, maybe to present their data in a different way, or collaborate in a different way. Can I give an example of?
Totally. Yeah,
Um,
yeah. I'm dying to hear what your favorites were and your take
well,
home.
I think in the name of nerddom and passion and intensity, there was a talk on new onset diabetes, and where do you put your focus, or how do you prioritize? And the first speaker was Dr. Anya Jastreboff, which I'm used to seeing her name and um, being in conferences or moderating talks, things like that, where she's really very much talking obesity medicine. But it was just great to hear that straddle. But in that talk, it was, do you treat obesity first? Do you focus on preventing the complications? Do you focus on remission, or do you just focus on the blood sugar? In my obesity medicine brain, I thought, well, these things don't have to be exclusive of each other. They are either on a spectrum overlapping, but each person presented their that position very in a very compelling and animated way. But she went
Oh, wow.
first, and so hers was treat obesity first, which was with or without medication, but more in a chronic disease management model. And thinking about that spectrum of chronic disease could include type 2 diabetes, as well as the other complications. So that, for that to be like the first thing that I jumped into, was able to listen to start to finish, I thought, well, it's going to ease my brain into thinking about obesity medicine or obesity treatment in the context of all the other research with diabetes. So it was good. It was good.
I think she's a fantastic speaker, and I think she really does a good job. Again, like you said, straddling that. I think she's trained as an endocrinologist, clinical
Yes.
endocrinologist,
Yeah.
but we know her name, from being at Yale and being part of some of the clinical trials that we're hearing
Yes.
about. So I think that's a good take home of really that overlap. And I felt the same almost in the way of hearing, knowing that it's not just diabetes or just obesity, and really starting to see
Hmm.
where that comes together. I think that's really an interesting component too. And I've focused a lot on the body composition side in
Hmm.
obesity care practices, but I was
Hmm.
interested to have conversations with some of the practicing endocrinologists and folks in this space, even diabetes educators, about what are
Hmm.
the patients who are on the medications for diabetes. I think
Hmm.
a big take home is that we talk a lot about these being new medications, right?
Yes.
And they're like,
Hmm.
we've had options in this category for a really long time. So
Right.
quit calling them new, right?
Yes.
So they have had first, second, third generation. Maybe that's the more appropriate language to use.
Yes.
But I was interested to hear, what are their thoughts on body composition changes, and are they measuring body composition in their practice? Are they,
Yeah.
how are they dealing with that after having these options for many more years for patients with, I don't want to say just diabetes,
Right.
but for like the primary treatment had been medications for diabetes with a side effect of weight loss, and how do they
Right.
investigate, is that weight loss appropriate, where is that coming from, and what do they do with that when it's coming from more fat-free mass versus fat mass.
Right. And to your point, I do think both in obesity professional society meetings and what I observed for the sessions that I attended at ADA is that I'm hearing a shift in the narrative of uh, making someone's body pathology, just globally saying
Mm.
they have overweight, they have obesity, their BMI is high, and it's like that's all the pathology. I'm hearing a shift of, we're really concerned about how do we um, assess and mitigate the risk of excess adiposity, but take as holistic a picture as possible about the patient so that as we move through these different treatments, how are we going to measure success? And if success used to be weight, because too much weight was like, I heard in a couple sessions, it's the reduction of the fat mass. Maybe they didn't balance it with other compartments, other parts, but it wasn't singularly focused on it's this much weight. It's really our endpoints for success would be, improved glycemia, improved fat mass or adiposity, and then, weight would come after that. And that, I think, that was another, I keep saying comforting. I think it's because my ears hear things a certain way for so many years in obesity medicine that when I go to other spaces, I'm not always expecting to hear it shared in the same way. But I thought it was comforting to know that other disciplines, other professions, that we're trying to make this collective shift to why did we first focus on weight to begin with? And now that we know more, how can we do more, learn more, share more with our patients to reframe this concept of success or progress? So I actually heard that, I'm trying to think of this session. It was actually on a gene therapy session.
Oh, okay.
On pancreatic gene therapy after the withdrawal of semaglutide. And I'd have to look at my notes to get in the weeds of that nerddom. But in the end, if someone was on semaglutide and used it for a duration of time and then it was withdrawn, if they had this one dose pancreatic gene therapy, in the end they were still able to have improvement to glycemic control, improvement to fat mass. I'm not sure if it was stability of weight or weight reduction, but achieve that without inflammation of the pancreas. But it was all kind of wrapped up in a medication discussion, but then it's that brave new world of gene therapy. But it's still kind of speaking a language that if a patient resonates with multiple messages or just one message, I felt like there was something in those results that, maybe I really don't care about my fat mass as a patient, right? But I care about my blood sugar control. Or maybe I have a different level of health literacy and I want to know more about that. And I'm thinking it's going to help my blood sugar control. I just felt like there was a little bit for everyone to kind of tap into and watch out for that as a way to consider what happens after medication's withdrawn or it's stopped, or what if this is a nuance to the concept of chronic disease management or the spectrum of that. You get to this part of treatment, you deprescribe, you change whatever, but what would the next step be? That, my friend, was when I fell all just headfirst into Nerdville of I could sit here and listen to this forever, but it was, very, very time efficient. It was about 20 minutes, 25 minutes. That's as far as I got with it, but it's something that I'm keeping an eye on.
I thought that the it's not one size fits all approach was definitely a not just an underlying, but a big theme. And I'm just always happy to hear that. I think no matter where we are, we have to keep pushing that, because it's like you hear a study, you hear a finding, it sounds really great. You want to replicate that in your patients. You want to bring that information home, but it really has to always go back to patient values, provider experience, and that new, information and that evidence-based practice approach. And I felt like they did a good job with that from my perspective too.
And things are changing so fast. Let me rephrase that. We are learning so much, in my opinion, at a faster pace than I can recall in other parts of my career in medicine, that let's say you are a slow adopter as a clinician, and you say well, well, let me see if they can replicate that, or let me see if there's more evidence. And just as soon as you think you are ready to adopt something, there's another nuance added to it, or there's something else to round out that discussion. It might not sway you one way or the other, but we're just learning so much, and that's where I think the spirit of innovation will serve patients best if we lean into that. That it won't be static, it won't be what we did before. It can't be what we did before because we have evidence to the contrary. We learned from it, and we learned that we wanted something more or better or different, and now these are all the learnings. And I just really find that part fascinating. That if you just sit back and read the science, wait for the evidence base, even as someone who thinks that you're experienced with 20 years or however many, there's something to learn. When you go into work or when you open up that journal, there's something there to learn that you didn't know maybe the week before. So
And there's so many new agents coming out too. I mean, that was something that was a little almost overwhelming, definitely overwhelming.
yeah,
And I didn't attend all of those talks, but just hearing about new agents in development, I think they said something like more than 20 new ones that they were talking about there.
right.
And I think even where I did hear some of the body comp stuff coming out is talking about, side effects, contraindications, managing
Mm-hmm.
it from the patient level, but the
Mm-hmm.
innovation side of let's find, well, if a downside of this could be that someone loses too much fat-free mass or lean mass,
Mm-hmm.
they're developing and looking at different mechanisms to these medications
Mm-hmm.
that would preserve that component or build.
Mm-hmm.
And again, that part is probably over my head of how it
Mm-hmm.
does that and what might be the right combination that does that.
Mm-hmm.
To me,
Mm-hmm.
again, my practical side and take home is, well, amazing innovation, but let's make sure that that focus still is on how that's impacting the patient, what the patient
Absolutely.
can actually do on their in their sphere of responsibility. And then
Right.
from a body count perspective, of course, it's just measure it. Let's
Yeah.
see. We don't know which ones are going to be the right ones, and just think about those algorithms for treatment, right? Once you have more
Yeah.
than two agents for on
Mm-hmm.
the obesity side, I don't know how many are approved on the diabetes side right now, but once you have multiple agents, you really can start to get a much better, I'm visualizing a little decision tree of if they have
Mm-hmm.
this, and that appreciates the nuance of a different patient's background and experience and
Yes.
goals and what they're able to afford, and the affordability piece, of course, was not lost on this group as well. But I do
Right.
feel like a little bit more focus on the um, just the differences and the nuances in some of the medication options that are coming.
Yeah. And I think you hit it on the head when you said nuance, because I think what we're learning from the newer um, agents is also adding to our understanding of the mechanism of these diseases, or the cellular level pathology, whatever it is that would enlighten a clinician and their mindset to say, yes, people have free will, and some personal behaviors could impact disease management or disease progress. But if there was a part of you that thought, well, I just need to help them buckle down, or I need to really show them, tell them, just a hyper focus on personal behavior without the basic science and the clinical science awareness of what we're learning, that's where, for a patient, again, even if your clinician is a slow adopter, it's just planting those seeds of there are nuances to these disease states that we're learning, that the medications may help with weight reduction. Okay, but when we talk about other disease processes, is it that the medication has some other drug effect that, in addition to the weight reduction, it's helping that? Is it that if I was hyper focused on energy balance, because that's the bane of all existence, and I'm just going to focus on that, blinders for everything else, is there a more nuanced way, to your point, to approach, well, how do you balance that plate? How can it be a reflection of you, your culture, your access, your community, whatever that may be? I'm for anything that adds the nuance that allows more um, data input from the patient, right? Like, I don't know, my generation, at least my perception is when we were trained, it was a little bit more hierarchical in a therapeutic relationship. And I think generationally, in the signs of the times, is this is spread out. This is more shared decision making, but it also means we have to be willing to um, take the data information from the patient, input that into what we're considering for treatment, and then repeat that back in a way that resonates with them. So, to your point, is it what's the word? How does a patient feel when their clinician focuses on something different than the number on the scale?
Mm-hmm.
And how does the patient feel when the clinician asks, what are the main things on your plate, or what are the challenges for you?
What matters to you?
To get
That's the question.
exactly, yeah. But then to say, I might not have understood all the science that was presented, or maybe wanted to adopt it all, but it's all coming in such a way that I have to consider that this current path, this old path, former path, might need to be adjusted so that I can have conversations with my patients where we both feel like it's meaningful. And that goes back to my hope for the innovation, is that the clinician and the patient walk away feeling like that was a meaningful conversation. It didn't feel so one-sided, because now there's more room to get that more nuanced information, because there's more science to go with it. And maybe before it wasn't as well received because we didn't know, or it wasn't spelled out.
Perspective, and
Yeah.
mature enough to know that we didn't know back then what we know now, right?
Yeah, we'll never actually admit it, but we can wax prolific on it and consider it as part of the discussion anyway. So it's good.
So another kind of theme that I saw, I mean, of course, for me, one of the big ones was hearing about the surmount sleep apnea information, but really was about sleep, right? So we're hearing now it's about sleep, but it's also about, medications that are not just a target for one thing, right? Mentioned that, like we heard results of this trial where they looked at sleep apnea improvement, and I don't know the exact terminology, but now it's almost like the indication for this class of medications can be for sleep apnea, whereas prior to that, for sleep apnea, all you had were technologies, CPAP, different kind of treatment modalities that weren't medication. And so I think that's a big one. And really, to me, not only is it for patients with sleep apnea as a diagnosis, but it's sort of just with each conference we go to, with each time we're hearing these results, we're hearing more and more like this medication does so many really cool things, and it's neat to hear how they work for the different disease states, but also how important sleep is. And that's kind of like the untouched. Right. It's not untouched, but it's at the end of your, if you're in clinical practice and you're talking to patients about all these different components, nutrition, behavior, movement, where does sleep fall into that? I think it tends to get the one-liner of like, oh yeah, and get a good night's sleep, right? And so just like eat less, move more is not appropriate or helpful information to give someone. Probably like get a good night's sleep is kind of like flush your teeth, right? Like it's not actually translatable.
Right.
And that I thought was cool.
And to your point, it's like, were we sleeping on sleep, right? Like, no pun intended. Were we missing this chance to have another type of conversation? Because how does sleep affect your mood, to your point? How does it affect your food seeking, your perception of hunger? How does it affect your focus throughout the day? All those things that, if we weren't careful, we would over attribute it to something else that could isolate a patient and make them feel like, if I need to do something more, but it wasn't related to get rest and sleep. And so are we able to leverage the awareness, adoption, and utilization of some of these newer agents, are we able to leverage that to revisit some aspects of the basics? Sleep is basic. Like, you have to sleep. Culturally,
Simple but
digitally.
not easy, right? I like
Exactly.
framing it like that. It's simple to
Yeah.
say, "Oh, rest is pretty simple stuff," but how
Yeah.
many people do you know that truly get that
Yeah.
right?
And how we culturally um, adjusted the perception of sleep and rest, that it might have lost its importance or its value
Mm,
to other aspects of health. We sometimes rob ourselves of sleep because of productivity or other things, right? But what if then it's the gift that you give yourself because you're on this journey to better health, or you've identified, you know what, when I do sleep, my mood is better, or I focus better, my ability to take that walk, I have better stamina, I have less pain.
mm,
Or late at night, when I used to be up late at night, my food seeking would change. My hunger and satisfaction cues were a little bit harder to discern. But if I go to bed at a certain hour, maybe it's not that it goes away, but maybe it's just different. And I know I sound all corny about this, but I just feel like if that's just another way to have a conversation with a patient that resonates with them, and is resonant in a way that they feel seen and heard. Because if they come to the doctor and they say, I'm tired, doc, like I just don't feel like I have enough energy. And if the narrative is, well, you probably don't have enough energy because you have too much weight, I bet you if you lost some of that weight, you'd have more energy. You're like, okay, what do I do in the meantime? And do you take a more careful sleep history, to your point, and you feel, you realize, oh, I have learned something about their sleep that requires an intervention, and now I have more options for this intervention. And then if I address it, will they come back? And how does sleep affect the other parts of your hormones that then exacerbate the unfavorable ratio of body composition, or your interest or palatability for different foods, things like that. So uh, it's all good stuff to me. Something more to learn.
that was definitely one where I feel like and this illustrates what we're talking about here to wrap up perfectly. Getting there, getting the deep science, learning what's new and innovative and in the research department, and then having conversations like this where we
Yeah.
talk about what does that actually mean and how does that change our practice? How does
Right.
that change our conversations with patients? And in the realm of, I think, always keeping that front and center. How do we help patients feel seen and heard better? And how do we get all the way around to the metrics that matter to them,
Right.
even if the mechanism it's a pretty big arc, right?
Right.
From
Yeah.
new research to the actual person's behavior, but that's one where I think that does matter quite a bit to folks, and they can see tangibly improvements when they're getting better sleep, and if they happen to be able to manage their weight better and manage their blood sugar better and
Right.
manage their mood better. I mean, that really does seem like a win for all involved.
Yeah. No, I think that's a good way to round it out. It's the metrics that matter to them, but leveraging the evidence base that's that matters to us as clinicians to be able to convey that to them or have that conversation. So yeah.
Wow. Well, in 30 short minutes, I think I think we really processed some deep learning there at that conference, and I know that you and I will continue to talk about this and how we can
Yes.
help our healthcare providers do better in this realm. I think that's what matters to us,
Yeah.
and help patients feel seen and heard for the things that matter to them. I think that's it.
Absolutely. No,
We
I
can
think you're
retire
absolutely
now.
right. Listen, if only. Or we can just keep talking and keep finding those nerd rabbit holes and allow others to listen and enjoy. So this was
That's
great. I
right.
appreciate it.
As long as we have the platform, we'll keep doing what we do. And I,
That's
I
right.
really appreciate you having this conversation with me, and I look forward to many more.
Absolutely. Thank you
All
again.
right. Thanks.
All right.